I'm going to invite Dr. Ball to come back to the platform. I think we're sharing this duty, or oh no, I know who. Oh, my colleague. Oh yes, she's here. Oh, okay. So hold your questions. But that was very inspirational, right? You know, when you ask questions like, can we do this? And I'm the first one there saying yes, because what man has done, man can do. And I believe we can do anything. Come on, people. Years ago, we didn't think we would have a cell phone. You understand? And we have one now. There's nothing that we cannot do. And it first starts in the mind. If you can believe it, you can achieve it. You've heard that before? I believe it's true. Now, let me get to the next session. We're moving things along very quickly. Where are we? Where are we? What time is it, my people? My people. I'm not looking at time. I'm looking at where we are. Session 10. All right, there we go. So my super duper amazing entrepreneur and colleague, we also work at the same radio station. We've even shared a stage before because we're wannabe actresses. No, she's a very good actress. I'm a wannabe. And we have a lot of fun in our society whilst helping people. And I want to just acknowledge her because she's always helping a young person. And she has been supporting a young person from the children's home where I chair, the largest in Jamaica, 100 wards of state. I call them amazing children. And I want to thank her for contributing to that young person's success by just being there, being present, and supporting her with her resources. So ladies and gentlemen, your moderator for this next session on financing and regulating healthcare is, can I get a drum roll? Patria-Kaye, Aaron's media personality, CEO of Sweetie Confectionery, Jamaican entrepreneur. Long time I don't see you. Take over, lady. Give her a round of applause.
Folks, how you doing? You all right? So my name is Patria-Kaye, and you heard I'm a startup entrepreneur and I'm a freelance journalist, which means I'm just above the poverty line. And it means that for the last 5 years, I haven't had health insurance. And that's the reality of 80% of Jamaicans. 80% of the Jamaican population do not have health insurance. So it meant for me that I only went to the doctor when I thought I would die on that day. Outside of that, I would drink my bush tea, and I would sniff some rubbing alcohol and hope that all would be well. Now, I got married 2 weeks ago, and thank you. I love my husband plenty, plenty, plenty. But what I love, it's in the top 10 of reasons why I love being married, is that now I'm on my husband's health insurance. And so doctors in the room, you will be seeing me. We have some things to check out. But we're talking about the cost of health insurance today. Who should pay for it? Who can pay for it? There's this whole argument about health being wealth. But there's a whole nother conversation about, in Jamaica, health being for the wealthy. And we're talking about that in the session today. So, first up, it's not about me, it is about the folks who are going to be sharing information. And we're starting with Dr. Mark Anderson. He's going to be your first presenter. He has a long list of accomplishments. And the Johns Hopkins Hospital is very lucky to have him as the physician-in-chief there. And he's going to be sharing with you about medicine and society and the cost of not just healthcare, but high-quality healthcare. Please make him welcome.
All right, well, it's a pleasure to be back, and I'm going to try and do an expansive lecture pretty quickly. And so I'm going to talk about healthcare, and I'm mostly going to talk about healthcare in the United States. I'm going to try and predict a little bit, but I think what I have to say will have a lot to do with this value proposition that we've discussed here. I want to just disclose that I am not a seer. I cannot predict the future. and then I'm going to focus mostly on the health system that I know best. So I'm going to just tell you that this was my overview. I'm going to truncate this a little bit, but I'm going to try and touch on just sort of an overview of the U.S. healthcare system, really dwell a little bit on this problem of cost, because that is a major reason that we don't have value in our healthcare system. I'm going to look at some of the political process, and I'll try and touch on the Maryland model, which is really a unique model that is not a pay-for-activity, it's a pay-for-value attempt. I'm going to talk about disruptive innovation. We just heard about AI. There's a lot of disruption in healthcare right now, and I think some of it will have a halo effect and ripple through the world. I'm going to talk about population health, because the biggest challenges that we have here in Jamaica and the U.S. substantially overlap, and they have to do with obesity, diabetes, cardiovascular disease, and then just some thoughts, if I have time, on planning for a future. So does the past predict the future? We ask this a lot in finances, and the answer is probably not exactly, but it almost certainly informs what our future is likely to be. And these are just references. I don't have time then to touch on them, but I think that they're really helpful, particularly this white paper in the middle. There's the first 100 pages summarize the Paul Starr book in a much less dry and digestible way, and I think provides a really concise history of U.S. healthcare. So this is kind of, we talked about at the beginning of this conference, the role of history and not being able to understand things, even medical things, without understanding history. I believe that deeply. I'm only going to talk about the underlined part, which I think a defining, although there are many real defining elements to where we are in U.S. healthcare. If I had to pick a single one, I would say where we were at the end of World War II compared to most of the rest of the world, whereas we hadn't had a war in our country, so there was not destruction, and our economy was going great guns. And as people returned from the war, we finally locked in this connection between employment and healthcare. And nobody else really did it that way. And we have really suffered. I'll try to show that this link, rather than having public healthcare a right, having it be an accoutrement of employment has created a loss of value and very high cost. This is what the current government thinks, that they don't care about that and are going to try and disrupt it, perhaps not in the way that all of us would like, but I believe that the fact that healthcare is so much in the fore politically now, when it just went through a major change with the ACA, and before that, it was not since really Great Society that there was a major, major change. So the fact that it's come up again so quickly, I think, speaks to the importance of healthcare and just how much that is not working for regular people, even in a rich country like the United States. So I just want to now talk about cost, because this, I think, is one of the essential and distinguishing features between the U.S. healthcare and all other wealthy countries and how they do healthcare. This trajectory is really unsustainable. Right now, healthcare is about 20% of the GDP of the U.S. It's a cause for slow wage growth over the last 3 decades. And really, as I'll show you, it's very clear it's not supported. The spend is not supported by the value analysis. So these are just summary data of a variety of countries. The red bar says what the average spend is. I think this is data that are 10 years old, so you can ramp them up. Because right now in the United States, we pay about $10,000 per person for health care. This is not, and I mentioned in the first day, zip code is actually the most important predictor of how well people do in healthcare and how long they live. But still, when we talk about the average spend index for our population, it's 10,000. But the average spend is something like 3,000. And this is really just making the point that it's because every single thing we do is more expensive. Going to the hospital, drugs, ambulatory experiences. And this is a rate of growth in the percent of GDP. So you're not supposed to figure out what all those colored lines are, this rainbow of lines, but the one on the top, this little blue line decorated with dots is the rate of rise of cost in the US. And so even for a wealthy country, that is not a sustainable rise. Now, I think a number of people have shown this simple ratio as the definition of value as quality over the cost, or outcomes over the cost. And so if you kind of think about value, you have to say, well, referent to what exactly are you seeking value for? So this could be a long and complicated discussion. I think we should just focus here on the really fundamentals. And so you may not all agree with what I've chosen as the basics, but I think it's fair to say longevity, infant mortality, disability, disease prevention, and research would be ones that I would say are basic parameters to investigate value. I don't have time to go through all the data, but I think these data are provocative. Life expectancy, although people want a quality life, it's not just about long life. What you can see is at the far left of this, lifespan is highly linked to medical spend in a linear range, but over a pretty narrow range. And you see a very steep rise. But when you look at the United States, a huge outlier over to the right, really spending this is an adjusted for multiple different currency values, but spending something like 100 times more per person than in Cuba, and having essentially the same life expectancy. I think it's a strong illustration that this, at least that parameter of life, of longevity, isn't a value. There's a lot of reasons why that might be. One of them almost surely is, as somebody said here, it's better to prevent than to treat, that we invest not insufficiently in primary care and access to care to give simple treatments like for hypertension, and we're pretty good at doing very advanced things. I think one thing that's good is we are distinguished by high research spending, and one of the last speakers made this case that investing in research creates a return on investment that broadly benefits society. I believe that that's true. It doesn't speak always to healthcare, but I think it's a major part of healthcare. I'm just going to skip that. And we've seen some asymptotic relationships between spend and longevity, but one thing that we don't see is that we don't see a ceiling for how much, if we create more and more spend and more researchers, we don't see a leveling off to the productivity, at least in this case, is denominated in new patents. Now, one of the things that, as our economy has changed into a banking service and a data economy, it's created enormous wealth and enormous wealth disparities. And some of these people are really going after healthcare because of the cost to their business in large part. And I'm just going to say that it might not be surprising that there's been a flurry of acquisitions and mergers to try and control different parts of the healthcare delivery machinery, from ambulatory to drugs. One of the interesting things is Walmart in primary care. Walmart, there is, in the United States, 90-some% of the population is within 20 minutes of a Walmart. So Walmart is going to start delivering primary care. They already have a pharmacy. They're going to be doing imaging. They're going to have your data. And Amazon wants to do this, and Google wants to do this, and Facebook wants to do this. So this is a very interesting time. So these kinds of examples, I think, are examples of disruptive innovation. And we just heard about big data, and people who control the data will control a lot. This speaks to personalized medicine. How do you create the right spend to the right person at the right time? You need data to do that. Personal devices, I succumbed because I wanted to see if my heart fluttering was atrial fibrillation, so I bought an Apple Watch. I'd resisted, but everyone almost who has a smartphone anyway has a personal device that is chucking out data to people that to entities you know and sometimes don't know. Telemedicine, this fact that you can deliver care. We heard about surgery. Maybe that's harder to think about with heart surgery, but it's really easy to think about with all kinds of primary care models. And that allows for non-traditional health venues. Could be somebody's car or their living room. And at least we have a big generational divide. People talk a lot about millennials, but millennials tend not to yet have chronic diseases, and they are much less interested in having an annual physical exam, something where, by the way, there's not real data to support it, and where they would much rather talk to you or get data from an app or through their phone than to come in and have a personal relationship with you in many cases. I think a lot of our economy in healthcare is built on the value of certain diagnostic tests and interventional tests. Honestly, nowhere is this a bigger thing than in cardiovascular medicine, but there is, I think, the chance to disrupt a lot of that. One of the things is colonoscopy. This is a huge area of medical revenue, and if that screening could be done in a different way, that would be disruptive. So diabetes, obesity. At Johns Hopkins, we reckon that the biggest cost to our healthcare system over the next decade will be diabetes. And that's because it connects to so many other diseases, cardiovascular being the main one, probably. And one reason, not the only reason, but is obesity, the link between diabetes and obesity. This is a big problem here, and it's a big problem where I come as well. And I think that we touched on this in the first day, and that is, we want to provide the right medical care in the right place, but to really make people healthy, we heard that the biggest effects on longevity had to do with public health issues, with water, with food, with access to education, with a good job. And this is going to be true also for obesity and diabetes, that being sure that we create societal frameworks and build structures that make it possible for people to take control of their condition, more than just telling them, lose weight, don't eat sugar, don't smoke. I'm a scientist, and I still believe in science and technology, and I think this is one of the advantages of being at a place with research, or listening to research, or partnering to people who can take your ideas into the marketplace. This is a young gastroenterologist at Hopkins who has built a company that's had multiple rounds of funding to really use a non-digestible carbohydrate that can be taken as a pill, that coats the gut and acts as a kind of bariatric surgery in a pill. And I think there are a lot of smart young people everywhere, and figuring out how to get them in an educational system and listen to them, they are really naturals with big data and with apps and computers, and I think they will be part of the disruption and also the solution for what we're facing in healthcare. These are some examples. So what do I think healthcare will look like in, say, 10 years or 5 years? I think primary care will be changed a lot, and I think it will be done less by physicians, at least in a classical way. And I think that will bifurcate a lot between people who have chronic diseases like diabetes and heart disease and people who are fundamentally well. And I think those people will be taken care of in a much more transactional environment like a Walmart. I think big data is going to really affect pricing, care algorithms, and how we share health information, and that we're going to grow interesting technological and other non-physician interfaces. That I showed these mergers. I think that is going to continue to be financially driven, that we're going to have acquisitions and a merger of interesting and strange bedfellows in healthcare. I think the things about being paid for traditional services, this is a major driver for cardiovascular care, for example, in most environments. It turns out not so much in Maryland anymore, but this is going to shift. We heard someone, Dr. Ferrari from Penn, say he had heard of that, and we talk about it all the time, and we don't always know what the future looks like, but we're pretty sure fee-for-service payment will not exist in its present form, I think, in the next decade. That there's going to be more at-risk components, and I fear, and I'm quite certain, that there will be more regulation, not less. So some of the big unknowns, at least for us, we're having an election very soon, and I think that what's going to happen to the ACA, I hope that it will be built upon and not vanquished, because there's a lot of data to show that it's worked in the states that have adopted it in a full embrace. But I think, is Medicare for All going to happen? Will we slide in a different direction? What is going to happen with industry and the merger of various healthcare delivery organizations? And how will technologies change the way that we do healthcare? And then what kind of workforce will we need, and what will we need to develop? So this is what I think we should do, and that's really, I think, the end of my time. So thank you.
Thank you so very much, Dr. Anderson. Some great information there, and I certainly look forward to chapter next and seeing here in Jamaica when some of those things are going to be implemented, because right now, Dr. Google isn't cutting it. People are diagnosing themselves, treating themselves because Google's free, and we still have to have that conversation around, you know, the very base of society, that as much as healthcare is quote-unquote free in Jamaica, we still have that dilemma between quality and cost. And William, you're going to be talking about the workforce and the cost of healthcare and how that affects you. And I have a small factory of 10 people. And if one man catches a cold, I have a heart attack because he's not going to go to the doctor. He can't afford to stay out of work. So with that cold, he's coming to work. And the other 9 people in the factory are susceptible to catching that cold, and that can cripple me. So I can't even imagine what it's like running Wisynco with your hundreds of workers when 10 people catch a cold. I guess we'll hear about it. Please make William Mahfood welcome.
Good afternoon, everybody. I want to say thank you for having me. It is truly a pleasure, and you know, listening to Patria talking about her workforce of 10, and I think about our workforce just over 2,000, and the impact of, you know, I'll just give you one memory of chikungunya. Close to 70% of our entire workforce at some point during that chikungunya outbreak was absent. So the impact of, you know, those types of diseases or viral infections or whatever can have a huge impact on productivity. So I've been asked to speak a little bit about workforce productivity and health. I don't have a presentation, but I just wanted to give you a little background on productivity. First of all, it's an economic measure of output per unit of input. So if you have your inputs in manufacturing or production or distribution services, they include labor, capital, and output is typically measured in revenue, in our case in business, or in gross domestic product components, such as, you know, in manufacturing would be like inventories and so forth. Let me give you a little bit of now in the context of Jamaica. So a World Bank study of 2018 claimed that children born in Jamaica will only be or only achieve 54% of their productivity by the age of 18 due to education and health. I don't know how they measure that. I guess they go in and do a lot of research in the health facilities and then look at the educational facilities, and that dictates the outcomes. But they describe human capital as consisting of knowledge, skills, and health that people accumulate throughout their lives, enabling them to realize their potential as productive members of society. So when you look at Jamaica, in the Jamaican context and productivity, we have seen in the last between 1990 and 2010, a continuous decline in productivity on an annual basis to the tune of about 1.5%. There's a combination of factors in a lot of the research that has come out. You know, there is a combination of a decline in education capabilities, decline in health facilities, and also the workforce development. One of the other major factors is almost 85% of tertiary graduates migrate from Jamaica. And so what you end up with is a workforce to a large extent which are secondary school graduates and who are in many cases unskilled. They require a lot of training and development in order to become productive in their workforce. So you layer on top of that, and Patria mentioned this, the healthcare system. We, over the years, due to political expediency, have had governments giving away education, giving away healthcare in terms of election promises. And so what we have today are very, very challenged facilities. And in the case of the public healthcare system, very, very difficult capabilities for people who, like our workers, for example. So in addition to that, you have, as the previous speaker spoke to, the issues related to the impact of non-communicable diseases on workforce productivity. And that's where I'm going to speak a little bit in our context. So in Jamaica, it's estimated that workforce productivity over the next few years could be impacted to the tune of $47 billion due to the effect of NCDs. So how do we address that in an environment like Wisynco? And so Wisynco, our mission says we're to improve the lives of our people. When we employ people, and we have 2,200 employees in the group, our total throughout all our affiliates, almost 5,000 people. The number one benefit that people look for when they come to work at Wisynco is remuneration or salary. That is pretty typical of almost any person employing somebody. The first thing they want to know about is what is the salary. There are important other attributes such as the work environment, the sort of culture, etc. Those are also very important. The second most important thing for people that we interview at Wisynco is, does the company offer medical insurance? And you spoke to that, Patria, in your opening remarks, because medical insurance is seen as a way for people to have the benefit of being able to receive private medical treatment in Jamaica as opposed to going into the public health system. The public health facilities are very challenged, and therefore private health care becomes much more relevant to workers and their families. Wisynco pays for 100% of medical insurance for our employees, and through the schemes that we operate, the employees have their families and dependents as co-pay. The medical insurance plans in Jamaica have an extremely high utilization, somewhere around 90%. And what that means is that basically, almost on an annual basis, every single company that has medical insurance as a benefit for its employees gets an increase in the premiums. This is as a result of very, very high utilization. So at Wisynco, we measure productivity in many different ways. We look at things like performance. In many cases, and other companies do it as well, we measure profit per employee or revenue per employee. In our factories, where we can easily quantify output, we measure actual production, or in distribution centers, we will measure the number of cases that an employee will handle on a daily basis or a monthly basis. We have pay for performance incentive plans. We also have one of the most dynamic and aggressive profit share schemes in the country. The company pays 15% of its after-tax profit in profit share to our employees. And those are some of the factors that help to motivate on the remuneration side. But it is critical to realize that the impact of the health and the health facilities on our employees has a big impact on their productivity and their output. Every single employee has the opportunity to benefit from areas that we look to improve the health of the workforce that we have. So we offer fitness classes for our employees island-wide. We do health screenings through the Cancer Society and also Heart Foundation for our employees, looking for identifying health lifestyle illnesses. In our canteens, which we offer subsidized meals to all employees, we offer more healthy alternatives, and we do a lot of education in terms of what to eat and what not to eat. We also offer, through our first aid and safety responders, we have training internally to focus on wellness at all levels in the company. All of these things are focusing on ways to improve the quality of the health in our employees. But at the end of the day, when the employees are, a child gets sick, with the recent dengue outbreak, for example, which was spoken of earlier, and the employee has to go without the benefit of medical insurance to the public facilities, there is much longer waiting time. So it significantly impacts on productivity. And at the end, so all of those factors, play a role on what happens in terms of the productivity. Finally, if we're to consider the impact of our healthcare on productivity generally in Jamaica, I think it's important that we look at a number of areas. We have a lot of discussion has taken place about taxing certain types of products, looking at the impact of certain types of packaging, for example, on the environment. All of these are important, but the reality is the most significant impacting, I think value-added thing that we can do in the country is focus on proper education. I think there needs to be a development of our education around healthy lifestyle. The Ministry of Health and Wellness now is focusing a lot on that. We need to focus on allowing people to learn about alternative foods and how to eat better. And I think through education, as a single focus, we can have a much greater impact on the quality of people's, their lives and the impact that they will have in terms of their productivity. And I'm going to finish early so that the other speakers will have more time. Thank you very much.